So thank you for putting up with us and allowing us to join your conference for our launch event. I'm going to run through 7 slides, and then we're going to hear from Jeremy Isaacs, and then you'll hear from my colleague, Professor Georgina Charlesworth, and co-leader of this, a bit more about what we're about, okay? And then there'll be some videos from our PPIE group. So I hope you enjoy and I hope it's useful. So, I'm Chris Fox. I say I'm an old-age psychiatrist. I'm based in Devon, Norfolk, and on the internet in general. I've worked for 10 years in the NHS, 10 years in the military, and then about 15 years in the academics. So I've got a sort of varied background. I'm laying out the sort of background there of what we're going to do this afternoon, as you can see in this sort of session we've got. We welcome questions at various points, and we'll signpost you to those when it's appropriate. Unfortunately, the minister's on video, so you can't question him. I'm sure some of you would like to. So what is the SPIN-D network? Well, it's not spinach, and it's not spinet. Some of you might have heard this morning we had a bit of a name problem a long time ago in a faraway galaxy. Some of us sat in a dark Teams room and came up with spinet, and then we realised the funder couldn't spell it, and neither could we, because there were double I's, double N's, and it did stand for something, double E's, double T's, and when you're writing grants and saying, oh, we're getting the support of SPINnet or SPONnet, they couldn't find it, and neither could anyone else, so we decided we had to do something about this damn name. So we did shorten it with our co-production partners, with input from PPIE and patients to sort of make it a bit more snappy, because what does SPINnet mean apart from a harpsichord or something to do with Germany, as I discovered from a colleague? There is actually a like harpsichord type thing called a spinet, but it's not relevant to brain health unless you think, well, music, I suppose. Anyway, it's a newly established network focused on brain health, risk reduction, co-production, engagement. It's promising a lot, but our area really focused on the vague clinical areas, or this is not an entirely medical clinical project, on prevention, brain health, and early support. We promised early support after diagnosis, which is the med tech bit, but basically, as you'll see as the day goes on and the session goes on, it's a whole lot more than that, and we are deeply embedded in evidence gathering, creating a living ecosystem where people can work with us or apply for money of us in small projects to bring in bigger and better solutions to current critical problems in our field of brain health and dementia. However, we're not alone, and some of these have got, I think, names that better than Spinet, but so Spin Dementia maps nicely with Empower, Equidem, and then working with dementia. A little bit about what they are. Working with dementia, and I don't mean to undermine the other networks, as work is looking at the working aspects of dementia and families. Equidem is about equality and looking at inclusion. And Empower is also empowering the voice of underserved and other people with dementia, carers, etc., to produce better research and to co-produce guidelines. And they're all doing that a little bit. So we sort of sit in the middle and they all overlap, but the great thing is they're all going to work together. And essentially, if you do the maths, there were 4 funded, and they're all going to run for about 48 to 60 months, depending on how much the budget was sliced. And they've all started. And we've put the contact details there, so we encourage you to reach out, and our partners, the other networks, are very keen if people want to. They've all got, or they will get websites, shall we say. So what did we say Spin Dementia would do? Well, what does it mean, spin? Because spin in a political sense has got a bad reputation. But what we meant by it was sustainability, P is prevention, I has 2 reasons, or 2 areas, I suppose, and you could say it's innovation, and then you do the big N for involvement. So that's the way we organised it. And as you can see, they're not going to read through the contents of this, but it's all about creating, building, and some of these networks in the past, in other areas, such as in vitro diagnostics, have been really successful about bringing patients, bringing academics, bringing clinicians, bringing companies together to create either projects, products, or change guidance. And I think that's what the funders really want to see, some impact. And one of the key things we're interested in is about sustaining beyond the 4 years, because I don't think, and I don't think Stephen can answer this either, there won't be much more money in 5 years or 10 years. And maybe if we get a boom, but the chances of getting recharges on these calls, we will see what happens. But we promised we would try our level best to become completely cost neutral in 4 years, i.e. get new income in, work with other grants, and also net zero we put in there. But we have a centre of net zero, which is about to launch, but that's another talk. So who are we? Everybody. We have 15 universities. There were approximately, and it changed, to 35 co-applicants. We promised we would cover the devolved nations, so we have a Scottish arm, a Welsh arm, and we do have a Northern Ireland arm which is developing as well as England, and we have many university partners, and we also have charity partners, including Dementia UK, which is not in the slide because we couldn't fit it on, but they are a partner. And we have industry. We had about 1.5 million of free gifts from industry, i.e. free data, free advice, how to innovate, offers of potential sort of internships. So that made it quite exciting. I think we were the only group to have UK industry support, and we are actively recruiting further companies that are appropriate to work with us in this journey. And there's the rest. I could go on and on. I spent 4 months creating a network of over 150 organisations for this bid. And luckily I've got a great team who have managed to extract from my files what they were, because it was like meeting, yes, great. And then we needed to keep track of those. And then all the staff changed. But as you can see there, I've also got local authorities, major charities, policy makers as well, and international links as well, which I haven't again put on the slide there. Next, we've got Jeremy Isaacs, a neurologist at St George's, and you are the new dementia lead for NHS England, taking over from Alistair Burns, who you may remember, who retired approximately a year or so ago, I think, wasn't it? And you're going to talk to us about NHS England and dementia, sort of.
Thank you, Chris. Thanks, Georgina. Thanks for having me to this meeting. And congratulations to the SPIN network on your funding and your project. And I wish you all the best with your work. And I was offered the opportunity to record a video message, but there's no way that I could have done something like that. I just don't work with pre-recorded videos. There's actually, if you look online, there's a video of me that I did for NHS London during the pandemic on memory services that are open for business. You can find it on YouTube. It's really embarrassing. So I'd much prefer to kind of be here in person and be a real human. So, dementia. So the context that we're operating in as a healthcare system and as a broader set of communities is as an ageing society. And I think that's something that we need to think about and understand very clearly, because it's going to have a big effect on the way we think about healthcare and the sort of conditions that we're going to be supporting people to live with. So this is some data on the population structure. And what you're looking at here are curves of people living into old age over time. And if you look at what this shows is that the numbers of people, the percentage of the population of people who are over 65, over 75 and over 85 are increasing significantly from the point at which most people in this room were born all the way through to the middle of the century. And what this means is that by 2040, 25% of the population are going to be 65 and over. And that compares to that being really a much smaller portion of the population up till now. And the distribution of ageing is going to be very different in different parts of the country, something that Chris Whitty highlighted in his report on ageing in a healthy society recently. And that's shown on Health and Ageing Society. And that's shown here. And I was looking through his report in preparation for this talk, and I found these age structure graphs, and they are they're mind-boggling, actually, if you look at this. So on the left is the population structure by age in 3 predominantly rural communities. So you've got Ryedale in North Yorkshire, New Forest in Hampshire, and then North Norfolk. And on the right, we've got 3 urban settings, so Manchester, Hackney, and Newcastle upon Tyne. And you could be looking at 2 completely different countries if you look at the age structure here, right? So in our rural communities, we are looking at a predominantly older population, and in our cities, a predominantly young population. Maybe the one in Newcastle is because it's university town, but this means that the way in which we think about who's in our communities, what sort of services they're going to need, who's going to be staffing those services. These challenges are going to look very, very different in different places. It's worthwhile digging out. It's a very well thought through report. It's worth digging out and having a read through it and understanding the geographical differences that we're going to be dealing with. Now, this is going to have an impact on the numbers of people with dementia, because the dementias as a group of brain conditions are diseases of aging predominantly. And so if we have a situation where a quarter of the population is going to be age 65 and over, we are going to have more people with dementia. That's an inevitability. And that's despite the fact that we know, and I'll show you some of that data in a minute, that individual risk of dementia has actually come down over time. And that might be because of improvements in management of vascular risk. If you think about it, numbers of people now, older people who've been on antihypertensives for a long time, who've been on statins for a long time, who've been on antiplatelet agents as part of secondary stroke and cardiac protection, and people, efforts to bring down the amount of smoking in the population. So we're managing vascular risk. So that might be one reason why individual risk has been declining. But unfortunately, that is outstripped by this incredible increase in numbers of older people, which is it's a success story. More people are living longer. But they're bringing the increase, we're aging with our increased risks of dementia following us through into late life. And one of the things that I saw recently in some data, it's actually done 5 years ago, before the pandemic, but LSE made estimates of the numbers of people with mild, moderate and severe dementia. And they estimated that by 2040, there could be 1 million people in England alone with severe dementia. So we are thinking not just about an overall increase in the numbers of people, but potentially looking at people living with more severe forms of the disease for longer. So we may be looking at not a qualitative change in the numbers of people with severe dementia, as well as an overall increase. And all of this is going to have an impact on the health and social care system. So this is just looking at the cost of dementia for society. And the bit of the system that I kind of sit in, which is the healthcare system, really has the smallest bill, if you like, if you want to put it in those terms, just over 4 billion. The largest single component of cost of dementia falls on unpaid carers. It's the cost that families endure and individuals endure. But all of this is going to increase inevitably as we have more people with the condition. Now, from an NHS point of view, this brings many, many challenges, but also some opportunities. And we've just listed some of them on here. And one or two of these I'll pick up on in a moment in the following slides. So we know that there are modifiable risk factors for dementia. Stephen Kinnock already mentioned those. And that these globally, not necessarily in the UK, but globally account for 45% of cases, which then could be potentially delayed or prevented if we address them maximally. We know that, and Alistair, my predecessor, had this nice phrase, he said, dementia rarely travels alone. So 9 in 10 people with dementia are living with another long-term condition. We have something called the dementia diagnosis rate, which is an estimate of the number of people with dementia who have a diagnosis, and it's currently at 65.5%. So it's almost back up to the 2/3 national ambition, and that will be reached next year, we think, at some point. But if we really do have another third of people with dementia, in addition to those that we've diagnosed, we might have to increase capacity if we got everyone diagnosed and everyone accessing the care and treatment that they need. We know that 43% of people with dementia who are in an acute hospital are there because of some condition like an infection that might have been manageable in the community had it been picked up earlier. And so, for example, I had a call last week with one of the national clinical directors for acute care, who's very worried about with winter pressure, with winter coming, the increase in respiratory tract infections. Is the NHS thinking proactively enough about people who are living with dementia and potentially presenting late with respiratory symptoms, which could have been picked up earlier if we understood the way in which respiratory illness looks different in people with dementia, and getting people antivirals and other forms of treatment in the community earlier. So this is something that we need to be thinking about. And then we know that if you go into any hospital, you're going to find a very large number of people there with dementia. There's a lot of people with dementia in hospital, and I'll be treating them appropriately. Now, I'll say a little bit about prevention. So these are the Lancet Commission risk factors, which will be very familiar to you. And we'll talk in a minute about what we might already be doing around some of these. But of course, what's not in the Lancet Commission, but something that we recognise, and Stephen Kinnock alluded to it, is that we know that deprivation is a major risk factor and a modifiable risk factor for dementia, and all of these, there's intersectional issues with all of these and deprivation. And we also know that being from a ethnic minority community increases risk. So we're aware of these, and there's a question about what are we actually doing at the moment to try and address them. So if you think about the well pathway that structures our thinking, at the beginning of it was in dementia, at the beginning it was always preventing well. But what have we actually done in this space up till now? And the answer is that there has always been, in recent years, an NHS England prevention programme, and it has a number of reasonably well-funded programmes in it that may be relevant. So there's a weight management programme, the diabetes programme, cardiovascular disease, alcohol, stopping smoking, and social prescribing. So there are people at NHS England who are interested in prevention, been working on this for a while. And if we then look at the life course diagram that the Lancet Commission used, and we think about some of the things that we're already trying to address through the NHS, actually a lot of these are my ticks, by the way, so I've annotated this thinking, what are we actually doing? And so, there is actually policy around cholesterol management in primary care. We have been thinking about physical activity and how to address that through social prescribing. There is a national approach to diabetes, and we have smoking and high blood pressure. And obesity. These are things that the NHS thinks about a lot. Interestingly, hearing loss is not something where we have been thinking about that systematically across the NHS, and certainly not in connection with its association with increased dementia risk. So that might be something where we could do more. And we shouldn't be nihilistic about this. We can definitely make some differences. So these graphs will be familiar to anyone who's been interested in dementia epidemiology. This is from CFAS-2. On the left, you have the prevalence data. On the right, you have the incidence data for dementia. And what we saw between the two epochs of the CFAS 1 and 2 studies was a decline in the age-specific prevalence incidence of dementia, and quite a noticeable decline, a meaningful decline. And we are still debating why this happened and what it's about, but what it shows us is that we can make a difference. We can actually reduce population risk. So it's worth doing. Now let's just talk a little bit in the last few slides about the sort of things that keep me awake at night, the sort of things that I'm here to try and work on. So this is variation by ICB. So these are the integrated care boards. These are the units, the local units of the NHS responsible for delivering the vast majority of healthcare. And this is a variation in the percentage of people with dementia being prescribed an antipsychotic medication. And you can see it varies from about 5% to 10%. So if you're in Greater Manchester, 1 in 20 people with dementia is being prescribed antipsychotic. If you're in certain part of Essex, it's 1 in 5 people. 1 in 10 people. So there's quite a difference. This is the percentage of people with dementia by ICB who've had a care plan review in primary care in the last year. And you can see it varies from 50% to 70%. So there is a lot of variation in the way in which people at local levels of organisation of the NHS are being supported or treated for their dementia. So these are some of the things that I've been trying to get my head around and articulate some priorities around in the last 6 months in the role. So supporting system performance is pretty much what NHS England is there to do. So we've been developing some system-facing resources. So Right Care is a kind of an example. It's a made-up story about someone living with dementia. And what you see if you look at it is an optimal pathway and a suboptimal pathway. And in that story, we bring out some good practice exemplars. So it's a kind of patient story. So it's worth looking up the Right Care scenario for dementia. It's a tool that's been used in other diseases as well. Diadem, which is a tool that was developed by the NHS in Yorkshire to support diagnosis of people with dementia in care homes, is something that we've been piloting in several ICBs around the country. And we're writing that up at the moment and evaluating it, and that might be something where we'll have more to say fairly soon. We have some other resources for the system coming out soon as well. The NHS actually measures quite a few things. You saw in the previous graph that we measured the number of people who've been prescribed antipsychotic medication. We measure the number of people having a care plan review. It's important to me that we make optimal use of the data that we have. And so I spend time talking to data teams. What data can we get hold of? What can we use to actually give us useful information about what we're doing and how it varies? We need to set the right ambitions for the system. So the diagnosis rate, is that the right ambition? What should be the ambition around diagnosis? What about waiting times in memory services? What should the right waiting time requirement be? We've recommissioned the National Audit of Dementia, and so that process will continue going forward. So that's a very important way in which we measure the quality of care in hospitals and in memory services and how that varies. Prevention is something that we do want to make some progress in, and we are in dialogue with the DENPRUs about that. So Stephen can mention the DENPRUs. So the DENPRU at Queen Mary's University of London is leading a programme on dementia prevention and what would be the priorities in that space. How do we take the things in that Lancing Commission life course diagram and those risk factors that you saw and think about what's the most parsimonious way for the NHS to respond to that, and what should the NHS do and what should public health do and what should government do. Something that's very important to me is to try to achieve consistent post-diagnostic care and support for people with dementia in the NHS. We don't have that at the moment. And fixing it requires that we have a model of care and that we have some funding around that. So that's something that I'm working on. It will take time, and these things take a bit of time, but I'm working on it. And then perhaps something that has taken up a bit of time, but is really probably, I think, the least important part of my role, is providing clinical support into the Alzheimer's DMT programme, because we do have a couple of new drugs that are going through the regulatory process, although they are probably not going to end up being nice supported. But it's important that that process has good clinical leadership. So I hope that was of some use and interest to you, just setting out what we're doing. I'm not sure there's time for questions, but I'm always happy to be questioned. Thank you very much.
So now it's my colleague, Professor Georgina Charlesworth.
I'm going to say a little bit about the sorts of things that Jeremy's been talking about and how that applies particularly to the SPIN network. Oh, I should say, Georgina Charlesworth, I'm at UCL and I'm a psychologist by background. So we've been talking about dementia prevention and about the modifiable risk factors. And anybody who's my age or older will know that there's been loads of scare stories about what causes dementia over the years. And there's times when we're all told to throw out aluminium pans and whatever else. And one of the concerns that we might all have is, well, how much can we rely on the information that's coming out? Some of the headlines about what's modifiable, are they really things that we can rely on? So I suppose in the network, we're trying to take an approach where we're taking into account the best available evidence at the moment, but we're trying not to get caught up in any hype about, well, here's a magical thing that's going to make all the difference. We know there's some groups that are known to be at higher risk of developing dementia than others, and that's not necessarily the same set of people who are engaging at the moment with the ideas about modifiable risk factors. So within the network, we want to make sure that we're involving some of the groups that otherwise might we not usually hear about. So, for example, Down syndrome is something that is associated with a particularly high prevalence of dementia. But how often do we do things jointly between groups of dementia and groups with people with learning disability? People who have severe mental illness, for example, who've lived with schizophrenia, are at far higher risk of developing dementia. But how often are we making sure that the dementia work is jointly with the severe and enduring mental illness sort of groups? And we know that for people who have neurodegenerative conditions that perhaps don't start with cognitive impairment, but start with movement disorders, or for people with physical health difficulties that are associated with cerebrovascular events, also at particularly high risk of developing dementia. So when we're thinking of our messaging, we need to bear in mind that there's some people who are already starting to feel guilty that they've developed dementia because they didn't look after themselves well enough. And I think we need to be really careful that we're not setting up messages that have unintended consequences, such as making people feel that it's their fault in some way that they've developed dementia. We still don't know anything like enough to understand what's actually relevant to each one of us as individuals. A lot of the data that we're talking about, the sorts of things that Jeremy was explaining to us now, it's population level data, it's epidemiological data, it's, as he pointed out, it's the sorts of things that helps us make a difference if we look across the whole population. But that doesn't mean that any one of us can apply that to ourselves, because we're still working on this whole business about how do any one of us as individuals have any sense about what our personal sort of risks might be. So I suppose that's one aspect to say, that we're not diving just straight into the woohoo, here's modifiable risk factors, let's try to suggest to everybody that they as individuals put all of their efforts and energies into that. We're saying, hang on a moment, we know that actually there's a whole range of risks that might not be modifiable, but that do make a difference to the likelihood that people are going to receive a dementia diagnosis, and therefore the likelihood that they're going to need the care and support after that diagnosis. So I don't need to repeat the top part of this slide, because we've had the introduction to the 14 modifiable risk factors. I've made the point that it's there as headline-grabbing material. We might be able to prevent 45%. Again, as we've just heard, this is something that's about global data, it's about epidemiological data. It certainly isn't something that's going to sort of shift any one of our personal sort of risk, but modifiable risk factors remain important. And if we go back to the examples I was saying about people with Down syndrome, we know that even though genetically there's the higher risk that somebody with Down syndrome might develop Alzheimer's, we know there's people who are now living into later life with Down syndrome above the age of 65, but still not developing dementia. And so somehow or other, even people with high genetic risk are able to not develop the dementia. So us learning from how it is that some people manage to have that resilience, what can we do to enhance cognitive reserve, what can we do to enhance resilience, to support people to be delaying the onset of dementia and also living well after the diagnosis. Another question that's come up often to do with the prevention messaging is, where does the responsibilities lie? Is it with an individual to maximise the attention they're paying to their own health, or is it up to society, is it up to government policy to make life easier for us to do good health behaviours? And now this is a little graphic that's really very old now, and that's why it's fuzzy, because it's old. And it was from a World Health Organization report in 1988. And the reason why I've included it here is because it illustrates the point that it's effortful for any one individual to be doing prevention action. But in actual fact, it's even harder for that any one individual if they're needing to deal with a whole range of different sort of social or health inequalities. And so the more that somebody's needing to struggle day to day with poverty or poor housing or unemployment, the harder it is to be taking the sorts of actions that might be recommended for good sort of personal healthy lifestyles. So again, in terms of the work that we're doing as a network, we're wanting to learn from the best research about individual behaviour change, but also making sure that we're thinking about the sorts of changes that we might be looking for in environments or within policy that might make it easier for all of us to shift the kinds of things that might otherwise expose us to higher risk of developing dementias. And in the network, our definition of prevention in actual covers the three types of prevention that you'll hear about within public health messaging. So it isn't just about the primary prevention, the preventing a disease before it even starts. It's also about supporting people around the time of diagnosis to make sure that there's the best possible support for health when the an illness is first identified, and then also trying to make sure that we prevent the degree of distress and social withdrawal that might happen once people have been diagnosed with a stigmatised illness. So I've got this slide as a summary of the things that I was talking about there, that we aim to innovate in the field of dementia prevention, but those three areas, primary, secondary and tertiary. But in terms of behaviour change, our definition is around a change in human systems for social and environmental good. And we will be looking to do that through understandings from data, so doing big data analyses, introducing new technologies and implementing and assessing those new technologies. And between now and when we finish, the main things we want to cover is the how to get involved. So I'm going to whip through these different messages, how to get involved. And this QR code here, hoping it's big enough and that people can see it on their phones either at the back there, that takes us through to our website. And the sorts of things I'm going to mention is becoming part of our collaborative network. And if you're interested, there's places to register that interest on the website. Consider bidding for the Flexible Fund, say a little bit more about that at the moment. Come along to events that you see us doing, or if you're holding an event and you would like us to come and join, let us know. Or we've got some interest groups both around the early career researchers and public involvement, and say something about social media as well. So the first thing that we're going to do out of those getting involved is to say something about the co-production and public involvement. We've got a team of people who are working on that, and we've got the list here, both our strategic co-production partners, our co-applicants, the leads at the University of Exeter, and our overall kind of involvement lead. And I'm very sorry this video finishes with a very silly look on my face. I don't know. Anyway, I won't say anything more about that. I'll just try and get it playing.
This video shows SPINDI's co-production and PPIE approach. Warning, acronym alert. SPINDI equals SPIN Dementia Network Plus. PPIE equals people, public, patient, involvement and engagement. We have the commitment, involvement, leadership and resources to make our co-production and PPIE approach work.
SPINDI believes that the involvement of people and carers with lived experience of dementia needs to be at the heart of SPINDI.
Is constant and integral to the whole process of research.
Will enable the development of excellent innovative models and processes for SPINDI.
SPINDI believes that people and carers living with dementia
are involved throughout SPINDI.
will know that things have changed because of their input into SPINDI.
Are equal partners in whatever they are doing in SPINDI.
Are part of the journey and must be involved throughout the whole process.
In recognition of equality and diversity, SPINDI organisational structures and members ensure and recognise that
everyone's experiences are different and will vary, and we need to remember this throughout everything we do.
There are real opportunities throughout SPINDI to involve a wider range of people with lived experience and to be as diverse as possible.
Specific actions to involve specific communities in research give the opportunity for people to get involved, break down barriers, including cultural and language barriers, and ensure that equity is embraced to enable inclusivity.
Everyone is an individual with individual experiences that are different and need to be reflected in our co-production.
Respect for difference is essential.
SPINDI influences the wider community by
becoming an exemplar for others to learn from and to lead by example on best practice around patient-public involvement and engagement and co-production.
Engaging with the public,
patients, carers, the NHS, social care, charities, researchers and clinical academics, as well as policymakers and industry.
Making SPINDI a state-of-the-art network involving people and carers living with dementia.
Strengthen connections between the experience, knowledge and resources of people across the network.
We want to become an international exemplar for others to learn from and to lead by example on the best practice around PPIE and co-production. Hi, I'm Professor Chris Fox. I'm an old age psychiatrist and I am a clinical researcher. I co-lead the SPINDI network with Professor Georgina Charlesworth. SPINDI is all about brain health, innovation, technology, working with patients, carers, looking at prevention, as well as industry, academics and clinicians.
Hello, I'm Georgina Charlesworth. I'm Professor of Clinical Psychology of Aging and Dementia at UCL, and I co-lead the SPIN Dementia Network with Chris Fox.
I'm Rachel Liverland. I work as part of Innovations in Dementia. We're a national community interest company, and we work on a whole range of projects in collaboration with people with dementia. And we are a strategic co-production partner on SPINDI.
Hi, my name's Di Burbage. I'm the Chief Operating Officer from Chinese Wellbeing. Chinese Wellbeing is a small charity based in Liverpool's Chinatown and has been supporting the needs of the older generation for over 35 years. We currently aim to keep people living in independent living for as long as possible. And we also provide dementia support services for those living with dementia and their carers. Chinese Wellbeing is a strategic co-production partner in SPINDI.
I'm Ruth Ely and I am chair of Together in Dementia Every Day, TIDE for short. We run an involvement network for carers, current and former carers of people with dementia, to connect them together and to help them have a voice. And we are delighted to be a strategic co-production partner for the SPIN Dementia Plus network.
My name is Bettina Wallace and I'm a co-applicant on SPINDI.
Hi, I'm Martin Robertson. I'm a co-applicant on SPINDI as a public representative, and I have dementia.
Hi, I'm Deborah Gingell and I'm the Public Involvement Coordinator for the SPINDI network.
I'm Jackie Parks and I'm the Involve Lead for SPINDI.
Hello there, I'm Shirley Evans and I'm Director of the Association for Dementia Studies at the University of Worcester, and I'm delighted to be working on the SPINDI Network Plus, and the aspect I'm working on is inclusion in small practice grants with Jürgen Grotz.
I'm Jürgen Grotz. I'm the Director of the Institute for Volunteering Research at the University of East Anglia. Within SPINDI, I'm working with colleagues on making available small grants.
My name is Ori McDermott. I'm a researcher based in the University of Nottingham. I am sharing a role of equality, diversity and inclusion role for SPINDI with Kritika.
I am Kritika Samsi from King's College London, and I'm co-lead of the Equality, Diversity and Inclusion work in the SPINDI network.
Hello, I'm Claire Hamilton. I'm the co-production and people and carers involvement lead for SPINDI alongside Kristen Liabo.
Hi, I'm Kristen Liabo and I am co-lead for patient and public involvement and co-production within the SPINDI network.
This video shows only some of the people involved in making our approach happen. We are recruiting a diverse group of people and carers to be involved in SPINDI activities. Please contact Deborah with questions and suggestions. Thank you, and please contact any of us with any questions.
Thank you very much for putting that together, and as Claire invited you to do, if any of you would like to make contact with the people who are on that, either do that via Deborah or you can go to the website and put the contact in the contact forms there. I mentioned the flexible funds, so I want to say a few words about that, which is that we've got 3 activities that we're funded to support in the network. First of all, the Micro Challenge Fund. So this is for small amounts of funding up to £5,000, which might be particularly relevant for PhD students or voluntary and community sector organisations that are wanting to do a little piece of research and get some input from researchers to help with that. And so it might be for something like needing money to do catering around a focus group or to be able to send out surveys. We've then got the Science Call Fund. Oh, I think I've got a little bit more detail about that in a moment. And then we're also carrying out interactive workshops, which will be about bringing together the different stakeholders that we've talked about today. So there we are. So here's a little bit more about the microfunding, as I was saying, for PhD students particularly, and we're trying to make sure that the administrative burden is as light as it possibly can be for these sort of small amounts of money. The slightly bigger but still quite small funds is for the sorts of projects that might suit early career researchers at different stages, and it might be things like analysis of existing data sets or doing very small sort of pilot studies or proof of concept studies. So we're thinking in the region of £15,000 to £30,000, and over the life of the SPIN network we're hoping to fund somewhere between 10 to 12 sort of projects on that, and the ambition is that those projects might lead the researchers to then have the opportunity to go for slightly larger sort of funding. We mentioned early career researchers there, and we've got Thomasina and Nick, who are here in the audience, are leading on that early career researcher stream with their colleague Hannah Wheat. And the intention is that early career researchers will be involved in a number of the different activities for the network. If you are an early career researcher yourself and you'd like to sort of join this network, there's places that you can do that, again, kind of on the website. And, oh, that's looking in the wrong place. So in terms of upcoming activities and events, we have got outreach and engagement plans over the next few months, but are up for invitations for anybody that's doing anything further into the future. So our first science festival will be in Norwich in February half term. We'll be running the sandpits, which, as I say, are the interactive workshops for the development of ideas and teams. First one will be sometime in early February, and then our annual conference will be sometime in late spring. And for the final few moments, pass back to Chris.
Thank you, Georgina. I see SPIN-D as a springboard to supercharge research in the areas that it's focusing on. And the one thing that I did raise with the funders, and I've raised in various NIHR institutions, is we've got a limited amount of money. I mean, the NIHR, I think, has £1 billion budget a year. I think, and the network leads, and Lucy Chappelle has said, it's all about collaboration now, less about competition if we can. So if we can build teams, so we can get more for our money, basically, because if people collaborate, you get you get better outputs. You don't get one team doing a systematic review on one subject, another team doing the same systematic review, which is a waste of public money. So I'm encouraging people to work together. There's an example already with the Connect Pluses where they did something on in vitro diagnosis, and they basically had monthly meetings where they could turn up and people could present ideas. And from that, they built 3 massive program grants in their 4 years, which were highly successful with new teams. And in fact, they all 3 got funded with slightly different members of the network. And not all the members of the network were, shall we say, originators. They applied to join the Connect Pluses. And it's also seen as a badge of honour and credibility, potentially, I think, in funders when they see that and the reputation of the networks get out. So I encourage it. It's a call to arms for researchers in the critical area of research, which all of us in this room are hopefully interested in, which is dementia. I've put in other bits about science fairs. We talked about those. I also would say that anyone who wants to join our network as an associate can do, and then we would encourage you to sort of spread the word through association. So if you're going to talks, like I was in Geneva and I just chucked it in, I chucked in HR, I chucked in all sorts of stuff in my talks, even nothing to do with the actual presentation, but just so that then you get the message out there and the branding, which is important, certainly on the global stage, but also nationally. Finally, the money will be announced, how to get and apply for it. Because people say to me, I want to apply tomorrow, how do I do it? There's a QR code. This is a launch event. Keep your eyes and ears open. Come to the website. And then there'll be appropriate ways of applying. We're trying to make it as light touch as we can. I think to mention, the boring bit about funding is it's only 80% costed because it's ESRC, so there has to be some core money brought in as well. But hopefully we'll get additional funding, or we can spread these funding packages and maybe make them bigger as we work with other, shall we say, sources of funding. That's all I've got to say, though. And there we go. This is the disclaimer. Thank you for listening.